Hello, and welcome to Roy Castle Lung Cancer Foundation's podcast. We support people affected by all forms of lung cancer and work to raise awareness of symptoms to ensure more people are diagnosed earlier. We fund research into early detection and patient experience, as well as providing life-changing support services to people who are living with lung cancer. We're thrilled to be launching our Let's Talk About Lung Cancer podcast. With this and the coming episodes, we hope to educate, inform and encourage more conversations around lung cancer, because the reality is, lung cancer can affect anyone. In this episode, Lorraine Dallas, our Director of Prevention, Information and Support, is joined by clinical oncologist David Gilligan and entrepreneur Peter Cowley, who is living with stage 4 lung cancer, to discuss tumours driven by genetic mutations.
Welcome to Roy Castle Lung Cancer Foundation's podcast, Let's Talk About Lung Cancer. This podcast is intended to explore the experience of treatment for those who have tumours that are driven by genetic mutations. I'm delighted to be joined by Peter Cowley, a patient advocate with experience of a genetically driven tumour, and David Gilligan, an oncologist and trustee for Roy Castle Lung Cancer Foundation. A warm welcome to both of you, and thank you very much for your time and sharing your experience with us.
Thank you, Lorraine.
Thank you.
David, as a clinician, I would imagine that some of the conversations you have with people regarding testing have to be managed quite sensitively. Knowledge about genetically driven lung cancers is relatively new and maybe very alien for people.
I think that lung cancer has moved on massively in the last decade or so. And we now have a number of treatments for specifically different or genetic differences within a lung cancer. Not all cancers will have a specific genetic mutation that can receive a drug that will hopefully improve the situation. But the number of, or the percentage of people with lung cancer in that situation is increasing. And when someone's diagnosed with advanced or stage 4 lung cancer, then it's really important to consider that they might have a genetic mutation in the tumor. And as things stand at the moment, that can be diagnosed in a couple of different ways. The standard would be to get a piece of the tumor, and it's important to try and explain to people the process that you have to go through to make that quite complicated or very specialist diagnosis. So you have a biopsy, a bit of the tumor is taken, and there are various ways of doing that, but it's usually a procedure that takes the form of a biopsy of either on the CT scanner or a bronchoscopy. And the first step is to make a diagnosis of, is this cancer or not? And that's done usually reasonably quickly, and there are lung cancer pathways which help us to make sure that people who are in that system get a diagnosis, or they get diagnosed with whatever is wrong with them, but in this case, lung cancer, in a reasonably quick way, usually within a week or 10 days. And that's just the diagnosis of what is this? Is this a cancer or is it something else? And if it is a cancer, is it lung cancer? And that's the first step. But then the second step, which is the importance for our discussion today about genetic testing, is something that there's an awful lot of work going on at the moment. And what the laboratory has to do is to basically take the cancer cells out and extract them, and then through very clever molecular biology techniques, detect whether there is a mutation in the tumor. Now, that is something which takes time, and it can take anything from, well, between 2 and 4 weeks, which, if someone's waiting for their diagnosis and waiting for a treatment which might influence that, is a really long time. At the moment, as we stand, it's on average taking about 3 weeks to get that result through. And so rather than have more standard treatments, such as chemotherapy or sometimes immunotherapy, it's important to try and wait for that genetic result to come through. Now, there are, and we can talk about, there are a whole range of genetic abnormalities, some of them more common, some of them less common, that need to be tested for, and the numbers of those are increasing. In Peter's case, there is, for the genetic mutation that he has, there is a blood test that can be done. And that, in Peter's case, that was very helpful and very advantageous because it did pick up in his bloodstream bits of cancer DNA, which could be analyzed more quickly and showed up this particular mutation. But that's just for that particular mutation. It doesn't show up any others, although there are tests that are being developed which will do that or are available. And the future might be that we have a blood test, or some people call a liquid biopsy, to make the diagnosis and get these genetic abnormalities back more quickly, maybe within a week or 10 days. So it's a rapidly changing field, in both in terms of the tests that can be done, the abnormalities that can be detected, in the treatments that can be delivered. But I think from a patient perspective, the really important thing is to make sure that we've got a test which is reliable and effective and is done as quickly as possible. And that's what people are working to try and streamline it.
Peter, what led to your diagnosis? And how aware were you before that about lung cancer?
Yeah, okay, I'll give you the 60-second version of this. I was aware, of course, but I associated, like many people, with people who smoked heavily. And the people who don't smoke and get lung cancer, unfortunately, it's usually, from what I hear, detected quite late. So about a month before something went wrong, I had some ataxia, some lack of balance. I'd actually done a half marathon in Cambridge, where I live. About a month later, I started about this balance issue. I went to a GP. He referred me to a neurologist. And at this point, I was lucky enough to be in the private system. So I had a private GP because my NHS GP was difficult to get hold of, etc. Neurologist quite soon afterwards. So there was only about 10 days between talking to the private GP and getting to a diagnosis of the first MRI of the secondary, as it turns out, tumours in the brain. About 10 days later, I got into Addenbrooke's, which is our NHS hospital in Cambridge, and got to the CT scan, and therefore the primary lung cancer was found. And then literally, and at this point I hadn't met David, literally about 10 days later, I've met David, the biopsies had all been done, and I was on the treatment. So I was so lucky that from the point where it actually got to the point where I needed to speak to a medic about it, it was only 30 days until I was on treatment.
What happened for you in terms of how well was the process of testing explained, and how long did you have to wait for your results?
That's a good question. So again, the short answer is that when the primary was found, they're going to do two. They're going to do an internal one and they're going to do a blood one, and both those were explained. And the actual internal one could have been through the chest wall or down the throat. I could have the throat one day earlier, so I had that at the Papworth Hospital, which is next to Addenbrooke's, a day later. So that was done. It was done. Actually, I've got a book that David wrote with the person who, you probably remember this book, David, don't you? The person who actually was inside me and took the biopsy. That actually proved to be of no use, what there was removed from there, because it was already dead, that material. But the circulating tumour DNA was analysed, and the whole thing took much less than I was told. I was told it would be a couple of weeks, and at that point the worry was extreme, because of course cancer people die of cancer in particularly stage 4 within a very short time. So, but it was only actually 9 days, and then I saw David on the 10th day, and he said, "This is how about using this drug?"
As a part of our commitment to helping anyone affected by lung cancer, we have a free lung cancer Ask the Nurse helpline to provide information, advice and support. You may want to know more about a lung cancer diagnosis, a type of treatment, or what support is available near you. Whatever your question, we will make time for you and go out of our way to give you the help and support you need. Call us now on 0800 358 7200.
Things are changing. So treatments that are available now and were perhaps just not around or available a couple of years ago. It is moving that quickly. And, you know, as we talk now, in a couple of years' time, there will be more treatments available that were just not available today in terms of being licensed or being developed or in research. Yeah.
And Peter, for you, the process of kind of coming to terms with the knowledge about your particular mutation-driven lung cancer and getting onto treatment happened relatively rapidly. How did you prepare yourself for your consultations, for deciding about treatment? And were there any things that you found over this period of coming to terms, finding out more about your lung cancer? Any strategies that you found helpful in terms of managing both those conversations with the medical team and the conversations at home with the family in terms of adjusting?
Yeah, that's a very big question. I obviously have been unlucky, if unlucky is the right term, to get cancer, but I've been very lucky that it's one, and the timing is such that I only found out recently, David, I'm not sure if this is true or not, that the therapy I'm on was only allowed by NICE a few months before I went onto it. So if I hadn't, no, obviously there are other treatments. There are second generation, I'm on a third generation, etc. So, but yeah, the things to do are avoid too much data that is going to frighten you. Take somebody with you so you can discuss it afterwards. And then, you know, the team behind David is also very helpful. But David's only got a certain amount of time with me. He's obviously got other patients, but the team behind will help with that as well. David, do you want to add anything to that in terms of how I was at that first meeting? Do you remember that first meeting in January? I do.
Yeah, I do. And I think from a clinician, it is absolutely vital, but somewhat unwritten, to try to understand how people will come at that whole process and that trauma, if you like, differently. So first thing to say is to absolutely agree to bring someone with you. Now, that person may be a friend, or it may be a relative. And it's important that, as you say, that there is more than also one person, one pair of ears listening to what's being said. And, you know, people may want to take notes or, with permission, record the conversation. And I think most clinicians are not too fazed by that, and will say yes. Clearly, different people do it in different ways. One general bit of advice that I do give to people: sometimes people want to bring the whole family or a whole group of people into the room, and everybody is different, but I kind of move away from that a little bit, because I think it detracts a little bit from the doctor-patient relationship, and that you're just answering a whole barrage of questions from the room. It's better that there is one, and sometimes two, but I think probably, you know, strike a balance of other people in the room who are there to support and ask questions. And again, every oncologist or every clinician will see things differently. Some people want a lot of information. Some people just don't want to engage. They just don't want to be told what to do. And that's what I come on to, the sort of the nuance and the sort of thing that's sort of not discussed very much, is that you have, as a clinician, what you have to try and do is walk a fine balance between trying to understand what that person wants, but not assuming that's what they want. And so you have to sort of feel and take clues, both verbal and non-verbal, from what they want to do. With you, it was very easy. You were very upfront, and you said, this is what I want, and these are the questions, and that you made it very clear, and it was very easy to give you what you felt that you needed. Other people, it can sometimes be more nuanced, and some people close away from the fact and want just to sort of not surprisingly want it to be happening to someone else, not them. And they have to, you may have to direct it through the person that comes with them. And some people are voracious for information, and other people are really just want to be told, take this tablet and we will do the rest. And so you have to kind of tailor your information and your communication to that person. But as I say, it's really important not to just suddenly assume, well, this is what you want and this is what I will do. So it is a dialogue between a clinician and a patient.
Yeah, I use the term joint venture, actually, which is strange. It's a business term, I know that, but I'm involved in business. And we work together, I believe, David and I do a lot of stuff in the background. I bring a list of symptoms or no symptoms at the moment and a list of questions, and I process it, and then I go away and come back. And we work together. It's a really important part of that. But it's feeling that you're in the room with somebody that is on your side, which you clearly are. The NHS is clearly on the side of every single patient, but in a way that works is really important.
We are proud to produce the only lung cancer magazine in the UK, Inspire. Each issue features inspirational stories, latest lung cancer news, medical and research updates, and the work being carried out by Roy Castle Lung Cancer Foundation. Read the latest issue now at roycastle.org.
I think you've picked up, both of you, a really important thing, which is about the relationship building. That means that for a clinician, they're not second guessing what it is that the person with the lung cancer wants, but also for the person with the diagnosis, that they feel as in control of a situation they would neither have chosen nor would want to be facing as possible. So for you, Peter, I'll kind of pass over to you in a minute to kind of follow up with some questions for David, but you've effectively become a very powerful advocate for yourself. Is that an important part for you of how you deal with a situation that you're facing that you would never have chosen and never have opted to experience?
It is, but it took me a bit of time to work that out. I did engineering and computer science to start with a long time ago, as I said earlier on, and my life has been a basic set of problems and solving. Really, that's what I am. It doesn't mean I'm not emotional at all. I can get very emotional, but that's what I do. So once I got my head cleared a bit, so there's several weeks that happened. Once I did that, then I package it up, and many people who will be listening to this will not understand this at all, but many will, hopefully. I package it up as something I've just got to work on, and we'll work on together. So yeah, that's just the way I think. I needed to, and I've got timelines, I've got spreadsheets, I've got all kinds of things, and this will come across more in the way that I'm sharing, on my YouTube channel, which is gradually getting subscribers.
You've taken a very proactive role in trying to find ways of coping for yourself, but also sharing that experience with other people. Can you tell us a bit more about that?
Yeah, again, that's a very interesting point. So I'm extrovert in various ways, and one of the ways is that I talk to other people and build up my own experience and knowledge and decisions. So, but I still had to work out who to tell when, and this is the same for all of us in this situation, whether it's a crisis in other ways or cancer. So obviously, clearly, immediate family, telling the kids was really difficult because they both were away at the time abroad, and so we had to do it on a Zoom call. Then telling other friends and so on, and then once you've decided who you're going to tell and not tell and how much you tell, it's much easier obviously telling the third set or fourth set or 10th set of friends into the beginning. Then it's how to keep them in touch. And the way I did it, in fact, because I have my own website, I put a password protected blog on there and just gave only a certain number of people the password to that. So that carried on for some months. So this is, and they're not just telling, it's receiving, of course. It's the advice, the support and the love and all the other things one needs once going through something, is particularly at a very late stage. I mean, I suspect even people are just as frightened if they got stage 1 as stage 4, but it's, seems a bit more, the end result seems a bit more concrete potentially, or sooner. And then I decided to go open with it only a few months ago, 2 or 3 months ago, as I've done before. I too, behind me, I have a book. I've written a book as well, but the actual content is to do with the field I've been in, which is entrepreneurship and investing in early stage companies. And so I've done that through a YouTube channel. So this means that effectively, if you look on my own website, it says I've got stage 4 cancer. But most people won't do that. They won't want to be as open as I have been. But building up your circles of support, deciding how to communicate with them is all part of that process. And, I had to work out how to do that. Hopefully, with the help of resources like yours and mine, etc., that other people won't be so thrown. We'll have something out there they can at least consider if they don't copy.
Peter, you said about not looking on things in the internet because it's out of date, and that's very true. And many people will come with bits of information from the internet or recommendations by friends, family, whatever, with absolutely the best of intentions, but they may not be relevant to that particular situation, because we are getting into genetically modified lung cancers is a form of personalized medicine. You're actually finding and zooming into treatments which are very specific to your particular cancer, and the treatment that you're on is not, for most people with cancer, would not be effective in any particular way. And so it's important to realize that there's lots and lots of information out there. I think that we have to, as healthcare professionals, we have to give people the information they want and give it in the form that they want and in the amount that they want. And there are various resources, and here is a plug for Roy Castle Lung Cancer Foundation in terms of the information that they give in formats which are either written or are on the internet, or are in so many different ways. And people need, through their lung cancer team, usually their lung cancer nurses, to find the information and the bits of information that are right for them in the amount and the time frame that it's appropriate to do so. The other thing that I think is really important, and you, Peter, I know that when you've come to see me, you've been fantastic, and it is a tip for other people to write down the things that they want to ask. Because first of all, when you come into the room, a lot of people, suddenly their mind goes a complete blank and they say, oh, there were so many things I wanted to ask you, but I just can't remember what they are. But if you've got it on your phone or on a bit of paper or in some form, then of course you can, you've got that as a reminder, and it makes the consultation, I hope, more productive and it doesn't mean to sound clinical, but more efficient, that you can give people the information they want and not spend time on things that are maybe not so important to them. But the other thing, which and I think you've shown me, Peter, is that there are bits of information or questions that you might have that we just can't answer. There may be, when you've got a diagnosis of advanced cancer, there are many things that you will experience, and some of them will be related to the disease, and some will be related to the treatment, but some will be related to something else. And these are the things that you might sort of notice for a day or two and then forget about in normal life if you hadn't got the diagnosis. But there may be things that that you've noticed that might be very significant to you, but we just can't pin on whether it's related to the disease or the treatment. And I think it's important that we as healthcare professionals are honest and say, well, I don't know, that might be something that is related, but equally it could be something that it's not in the list of recognized symptoms or side effects. It's just an idiosyncratic thing for you, or but we're always learning, and you can sometimes put together and say, oh yes, a few people have said that to me. It's not on the list of side effects that we are aware of, but yes, it could be related to the treatment, or it could be related to something else. But equally, there are things that we just cannot explain very well, and I think we just have to be honest and say, don't know. I can't say. We'll keep an eye on it, but these are things that are part and parcel of being treated and having having a cancer diagnosis.
Yes, the not the inevitability, but the chance of the cancer mutating away from the targeted therapy ion is quite high. I've seen the graphs. It's likely to happen in the next calendar year or some point. And I've talked to David several times about detecting that whatever, as early as possible, clearly, because there will almost certainly be a new treatment protocol at that point. How are we going to handle that, David, once it does almost certainly inevitably mutate?
I think it's a situation which you say is likely to happen and has to be handled carefully, sensitively, but honestly. And we hopefully do it in a way that sort of fulfills those fulfills your needs. Ideally, what would be great would be to say, yep, there's another treatment which is equally as effective and available, that you can just transfer from one to another. And in speaking generically, in some genetically modified lung cancers, that is the case, and there are always changes. And so in the case of EGFR mutated lung cancer, which becomes resistant to treatment, there are some new treatments coming through. It's impossible to say, because these things are subject to lots of regulatory authorities, etc., about when they might become available and whether they will become available in the UK and whether they'll become available on the NHS and whether they'll be licensed and when they'll be processed by NICE. And it's important to say that there may not be one particular treatment that will be recommended. It has to be done based on, of course, what's available, but also what the problem is. So sometimes there are tumors which will escape from the treatment, but there will only be one or two of the areas of disease which will be, and then they can be perhaps dealt with in a different way, for instance, with radiotherapy or some other what we call ablative therapies. But then if there is evidence that the disease has changed and progressed in a much more aggressive way in many other sites, then you may have to think about treatments which might be more conventional treatments like chemotherapy or immunotherapy or combinations of those. And so I think we have to be vigilant and pick these things up when they happen and look and see. As I say, we're talking about treatments, a treatment plan which is bespoke for the individual, and it has to be based on, as I say, the time of when it happens, what's available, what the problem is, how that problem is affecting the individual, how well or unwell they are with that particular problem. So I think, and when I discuss that with people, I think people feel perhaps a little bit, I won't say brushed off, but fobbed off, that you can't say, yes, it will be X, rather than it will be a range of things dependent on the circumstances at the time. I think in most cases there will be something, but it is very difficult to say it will be X. It might be it will be a range of things that can be offered depending on those circumstances.
We hope you've enjoyed this Let's Talk About Lung Cancer podcast. For even more information on all lung cancer related matters, please visit roycastle.org. We look forward to you joining us next time.